say hello and invite you to Dr. Michael Ashburn.
Good morning, everybody. I'm pleased to be here. I'm going to try to see if I can get the screen up and ready. I hope you see that.
Also, again, I will be recording this for anyone not in attendance that can view this information. So I hope everyone is okay with me recording. So I will start recording now.
All right. Can you confirm that the slides are up?
We see them.
Yes.
Okay. Thank you. Thank you very much. I just wanted to make sure. I'm delighted to be here today to talk to you about a little bit about xylazine. As was mentioned, I work part-time, not full-time, for the Office of National Drug Control Policy within the Office of Translational Research. But as this photo shows, I'm an itinerant traveler back and forth to DC, and my day job is actually as a professor of anesthesiology and critical care at University of Pennsylvania, where I direct the Division of Pain Medicine. I am boarded in addiction medicine as well as in pain medicine and palliative care. I've been thinking a lot and working on xylazine related issues, both at Penn and within ONDCP. But I speak today on behalf of in my role at Penn rather than ONDCP. The other thing I wanted to make sure that I shared with you that I recognize is that you all do work in a really unique environment, and I would not be so bold as to say that I understand all of the challenges that you face in the environment of caring for individuals who are incarcerated. And so my focus is really going to be on what we see nationally and locally with xylazine and what has been happening in the community on xylazine. And I leave it to you to do the translational work on making what we have to share work in your setting. Now, xylazine was first developed for use in humans after it was synthesized in 1962 by Bayer. There were some initial clinical trials in the mid-1960s. DEA reported that those trials were conducted as phase 1 trials, but the development of this drug in humans was abandoned fairly quickly due to concerns about severe hypotension and CNS depression in individuals who received the drug. Xylazine has never been approved for use in humans, and it is not currently a federally controlled substance, although several states have acted to make this drug a controlled substance. Xylazine was approved by the FDA for use in veterinary medicine, where it still is used in large game. It's used as a sedative that has potent analgesic and muscle relaxant properties, and it is used as a tranquilizer, and it works in really large animals. The large animal sedative dose is 0.2 milligrams per kilogram, which basically would be the equivalent, if one is to believe that interspecies variability does not exist, of about 14 milligrams in a 70 kilogram a dose. That's what's necessary to take a large game animal such as this and put them down on their side so people can operate and examine the animal. With regard to a broad overview of what's occurred with this drug, this slide presents a little bit of timeline. 1962, it was developed initially as an antihypertensive agent, but then abandoned. It was approved 10 years later for use in veterinary medicine. The first reported use of illicit use was from Puerto Rico in 2001. It started showing up intermittently in the United States in 2006. A significant rise in overdose deaths that had individuals had xylazine present was noted in 2019. In 2021, DEA requested the information to HHS as part of the initial steps in rescheduling the drug. In 2022, The FDA issued a xylazine warning letter, and in April of this year, the White House Office of National Drug Control Policy declared that fentanyl combined with xylazine was an emerging threat, which is a regulatory maneuver that allows for increased resources to be placed on a new emerging threat with regard to illicit drug use. Xylazine, again, was first identified as an adulterant in Puerto Rico. It was associated with significant number of drug-related deaths in the criminal justice hospital in Puerto Rico. Illicit use became widespread in Puerto Rico in the early 2000s, and then it made its way to Pennsylvania in 2006, where it started being identified. The presumption, which is yet to be proven, is that the initial intake of xylazine into the Northeast corridor tracked or followed fairly closely Puerto Rico immigration into the United States methods. However, I will tell you that that is not necessarily the case, particularly since illicit drug use comes from a different direction than Puerto Rico. Now, why add xylazine to the drug supply? Well, first of all, it's thought as being relatively inexpensive to access. And then, of course, it increases the profitability of selling a drug by net weight by putting an inexpensive bulking agent into the drug. It has a perceived low risk because the drug, until recently, was not regulated and law enforcement wasn't specifically focused on the drug. It was thought to improve the user experience in that the use of xylazine combined with fentanyl or heroin tended to extend the effect of the opioid, and it's versatile. This drug mixes with a variety of other drugs. It's currently been identified as being mixed with fentanyl, with heroin, with methamphetamine, and with cocaine, and it can be injected, snorted, it can be taken orally, and as a result, it's very versatile with regard to illicit use. The other issue that's associated with the drug, which may be perceived by some as a value for continuation for illicit uses, is that the drug causes intense withdrawal symptoms. Many providers are not prepared to treat this withdrawal, and as a result, when you talk to individuals who are using xylazine, they don't see quitting as a viable option. With regard to ingestion, again, it's very versatile. It can be injected, swallowed, smoked, snorted, or inhaled. When combined with fentanyl or heroin, the drug, what the users say is it makes you feel like you're in the old days of doing dope. They refer to xylazine giving the nod that heroin used to provide, that fentanyl, being a rapid-acting drug, really does not do. And some individuals have said that the use of xylazine in combination with fentanyl extends the fentanyl effects, and as a result, the injection frequency is a little bit lower. Now, the sources of xylazine, according to the DEA, is usually that this drug is obtained online, often from suppliers that are based in China. The drug is then mixed into the drug supply in the United States before distribution on the streets. It's less often mixed in Mexico. Xylazine, depending on where you are, is everywhere. When I interview or visit with individuals who are in Kensington and harm reduction programs in Kensington, they essentially say that all samples of dope have xylazine in them, and many of the samples have more xylazine, much more xylazine than fentanyl in them. Some of the older data, now it's older, it's 21 data, show that xylazine was found in over 90% of the illicit samples that were tested in Philadelphia in 1991. Xylazine has now been detected in tested samples that were seized by law enforcement in 48 states. So while initially was in the greater New York area, in the Philadelphia area, it spread widely in the Northeast corridor. It's been reported significant use in Florida and now in Georgia. There's a nidus of increased use in the greater Chicago area, and there's been initial reports of occasional use in the West. Street name is Tranq, Tranq refers to a drug that contains mainly xylazine, and Tranq dope is thought to be a product that contains xylazine and fentanyl in combination. But what's important to know is that when organizations, harm reduction organizations or city health departments are testing samples, even with the same logo on them, all the tested samples contain some level of xylazine. All of them contain fentanyl now instead of heroin. But what's interesting is that there's an extraordinarily high variability of content from one sample to the other sample, including those with the same package markings. I just reviewed some data from Philadelphia that was on a recent quarter data that showed that the concentration of xylazine varied from 21% to 45% in one group of samples that had the same markings. Now, the percentage of drug overdose deaths that involve xylazine are on the rise. This is a little bit messy sample. This is from the city of Philadelphia on overdose deaths and the drugs that are involved. Fentanyl far and away is by far and away the most common drug that's involved, but also concurrently, xylazine, which is pink, has been on the significant rise, particularly since 2015, and it seems to be a steep increase over the last 12 months. Now, one thing that I also want to talk about, this is a data slide that shows a similar rise in incidence on overdose deaths that have xylazine present is from Chicago. One thing I want to point out is that xylazine is rarely seen in overdoses or overdose deaths as the only drug associated with overdose. It's virtually always associated with another drug. That drug is most commonly fentanyl. Now, the number of deaths nationally are also on the rise. This is from a manuscript published in April in New England Journal of Medicine, showing the best data that we have from 2018 to 2021, showing a significant national overdose death rate associated with xylazine. One other thing to note on this death data are that it's incomplete and likely underestimates the true number of deaths that were associated with xylazine. And that is because different public health agencies and communities and pathology areas were not often testing for xylazine because they weren't aware that it was contributing to overdose deaths. And it's only been within the last year or so that drug overdose deaths associated with xylazine are getting widespread attention. In addition, there's a coding issue. There's actually no specific overdose code that refers to the drug xylazine. So they're using surrogate codes, and they've only now developed a unified nomenclature on which codes to use to classify these deaths. So I suspect that the 2022 data and particularly 2023 data, which will be much more revealing as we get better at tracking these deaths. I think it's also important to see that the region growth is changing fairly rapidly with regard to death rates, which of course, this is from the CDC report last month, shows that the death rates are concentrated in our region, in the region of Philadelphia and greater New York and Maryland. More is starting to spread from us westward. And there's been very little report of xylazine use in the West, but we fear that that's likely to change over time. Now, what I want to do for the next few minutes is spend a little bit of time talking about this drug class, because many physicians are aware of alpha-2 agonists, but it may be been a while since we've actually dove a little bit deeply into this drug and what this drug's effect is, and this helps guide our understanding of xylazine. Xylazine is a non-opioid alpha-2 agonist in the same drug class as clonidine and dexmedetomidine. Dexmedetomidine, as some of you know, is a drug called Precedex by its brand name. It's available as an IV infusion, and it's used as a sedative and an anesthetic agent in the OR and the ICU setting. The drugs from this class vary from their affinity for the alpha-2 versus the alpha-1 receptor. For instance, dexmedetomidine is 1620-1, alpha-2 preference to alpha-1. Clonidine, which many of you are aware of, is still available and used as an oral antihypertensive drug, and it's also available in transdermal formulations. It has a 200-1 affinity for alpha-2 versus alpha-1. And the lofloxacin, which is a drug that was approved in 2018 for the treatment of opioid withdrawal symptoms. So what do these drugs do? Centrally acting alpha-2 agonists lower the release of norepinephrine and epinephrine. They cause central effects that include sedation, analgesia, and euphoria. And clonidine partially blocks acute opioid withdrawal symptoms. And I'm sure many of you have used oral clonidine as part of your treatment program to try to treat the effects of opioid withdrawal. Alpha-2 agonists reduce the sympathetic outflow from the central nervous system. That leads to decreased peripheral vasoresistance, decreased heart rate, and lower blood pressure. Dexmedetomidine was a miracle drug. It provided significant advantages in the conduct of in certain settings for anesthesiologists. It's a D-isomer of medetomidine, which was synthesized in the late 1980s and was approved for ICU sedation and also as an anesthetic. What's interesting or what's helpful for this drug is most IV anesthetics cause respiratory depression. And as a result, we, as an anesthesiologist, we're always challenged with putting a patient to sleep, then paralyzing them, and then putting in a breathing tube as part of the conduct of a general anesthetic. There is a subset of patients in whom their airway may actually be technically difficult, or they may have a fractured cervical spine, or they may have an ENT cancer, where putting a patient to sleep and then relaxing them leads to rapid loss of control of the airway and an inability to ventilate the patients. Dexmedetomidine infusions actually provide profound analgesia and anesthesia, where the patient is lying still on an operating room table, still breathing, but analgesic enough where we can actually place a laryngoscope and intubate the patient. And that's profoundly anesthetic because that's quite a stimulating procedure. Clonidine is the oral agent that I think I want to talk a little bit with you because it's actually important in the discussion of treatment of xylazine withdrawal. Is available for oral or transdermal delivery. Its elimination half-life is 12 to 16 hours. It's metabolized 50% in the liver. The other 50% essentially is eliminated unchanged in the urine. The initial dose for the treatment of hypertension is 0.1 milligrams. Some of us start at 0.1 milligrams daily. Others start at 0.1 milligrams twice a day. The therapeutic dose is usually between 0.2 and 0.6 milligrams daily in divided doses when used for treatment of hypertension. Rare uses of up to 2.4 milligrams have been considered indicated, and there are some studies that show that the maximally or ceiling effect of the drug for use as an antihypertensive is around 2.4 milligrams. Incidentally, clonidine is profoundly analgesic, and there have been numerous studies on looking at the analgesic effect of clonidine when used as part of an anesthetic for major surgery. Now, one thing is that this drug class is not thought of as a drug of abuse, of course, until xylazine presented itself. But neither dexmedetomidine or clonidine or lafoxidine are controlled substances. However, there actually have been reports that clonidine, when used chronically, if it's stopped abruptly, can precipitate withdrawal symptoms. Those symptoms include nervousness, agitation, headache, tremor, and confusion. There have been rare reports of people who develop hypertensive encephalopathy, CVA, and death. The onset of withdrawal can be delayed, which makes recognition that the symptoms that are presenting are due to discontinuation of the medication difficult, because the onset of the symptoms could be 20 hours, up to 20 hours after discontinuation. And when you treat it appropriately, the treatment of clonidine withdrawal is usually a slow taper over 2 to 4 days to prevent the tapering or the withdrawal symptoms from presenting. Clonidine overdose also gives us some key information with regard to xylazine overdose. There's no specific antidote. Overdose is associated with rapid CNS depression. Patients become, just like I showed you on the infusion of dexmedetomidate, they become unresponsive and profoundly analgesic. Supportive care may be required, including protection of the airway, atropine for bradycardia if bradycardia is present, IV fluids to support pressure, and rarely vasopressor agents to treat hypotension. Interestingly enough, as the patients are experiencing overdose, they may initially have hypertension followed by profound hypotension. Now, some reports have stated that naloxone has a partial effect on respiratory depression associated with clonidine. I'm suspicious that that actually is not accurate, and that other studies looking at the use of naloxone in patients who have a combined xylazine and fentanyl overdose show that naloxone is effective for the effects on opioids, but has no effect on overdose associated with xylazine. There is a highly selective alpha-2 antagonist, which is available for use in veterinary medicine to reverse the acute effects of the drugs, and is also used to reverse the effects of dexmedetomidate, sedation in dogs. But it has not been studied extensively in humans, and it has not been approved for use in humans as a reversal agent for alpha-2 agonist overdose. So the next question is that current nomenclature for substance use disorders does not recognize alpha-2 agonists as having risk for development of a substance use disorder. Where there are actually some reports of individual case reports of people developing what certainly appears to be misuse, abuse, and addiction to clonidine, although it is rare. It has also been associated with combined use of alpha-2 agonists such as clonidine with opioids and other literature before we were aware that xylazine existed. But certainly tolerance and withdrawal are clearly present with all alpha-2 agonists. Withdrawal symptoms are severe and associated with risk of patients leaving, self-discharging themselves from the ED. And they also self-discharge themselves from methadone treatment programs if they are taking both, they seek treatment for their opioid use disorder, but withdrawal from xylazine is not currently treated when methadone is started. And there's a significant body of growing evidence that xylazine is being sought out, or at least continued, as a drug of illicit use. It does not appear, at least in my opinion, though, that the addiction potential of xylazine approaches in any way the addiction potential of opioids or cocaine. And I actually believe that the symptoms of withdrawal is what's preventing people from getting into treatment rather than their urges to continue to take the drug. So what are the risks associated with xylazine use? One is severe withdrawal, including hypertension, vomiting, and tachycardia. One is the physical effects while taking the drug, which include bradycardia, hypotension, CNS depression, and respiratory depression, particularly when used in combination with opioids. Prolonged unconsciousness can certainly lead to loss of circulation of extremities, as well as increased risk of aspiration and obstruction of the upper airway. Even if their ventilatory drive is patent, if their upper airway is obstructed, then they will have a respiratory arrest. And as many of you are aware, xylazine-associated wounds is a significant challenge. Xylazine-associated skin necrosis, which leads to loss of tissue, a significant risk of infection, and significant long-term harm to individuals are all issues of concern. Let's talk a little bit about the xylazine-associated tissue injury. Xylazine wounds are significant and horrific. The injury from the wounds can be remote from the site of injection, and the underlying etiology, at least to me, is unclear. There's been a lot of hypotheses, none of which seem to answer for all of the presence of the wounds. Some of it would say, well, you have decreased circulation. Well, decreased circulation wounds usually appear at the tips of the arms and the tips of the fingers first. These wounds often appear on the long axis, if you will, of the hands and the feet. They may be due to decreased circulation in the skin from these drugs, from hypoperfusion and then tissue breakdown. They can become necrotic and have terrible injuries that end up lead to these individuals seeking care. They develop secondary infections, and they often get down to bone or to ligament, certainly. Their xylazine-associated tissue injuries are a growing cause for hospitalization. Patients can present with bacteremia, dead limbs, horrific infected wounds. And unfortunately, the admissions are frequently non-curative, in that the patients remain in the hospital for 1 to 3 days. Therapy is initiated for the wounds, but the patients then develop severe withdrawal symptoms, which are often not recognized or not effectively treated. And then they self-discharge themselves only to be admitted later with worse wounds or worse disease. Now, xylazine wound care is actually quite unique. Interestingly enough, aggressive surgical treatment, which is usually provided by trauma surgeons, particularly those who have expertise in handling burn wounds, seems to be associated with poorer outcomes. Initial efforts to aggressively debride these wounds has been led to worsening outcomes or worsening breakdown of the wounds, and ultimately progress to amputations, which frequently end up being progressive amputations along the limb. What folks are learning now is that the aggressive first care starts with hygiene. The second is basic wound care. And what programs, this is a photograph from Savage Sisters in Kensington, is that having individuals come in, they go to the back, they're offered the opportunity to take a shower, they're offered an opportunity to get fresh, clean clothes, then they undergo fairly superficial cleaning of the wound with proper dry bandaging, and usually some tegaderm or other coverage of the bandage can lead to long-term healing if they get care. One of the key things that individuals have noted with regard to getting these wounds to heal is discontinuation of the xylazine. Continuation of the drug is associated with poor outcomes than in those individuals who are able to decrease or eliminate their use of xylazine. So what are some of the management challenges that folks have been facing? First of all, xylazine is not routinely detected by toxicology screens. So in many institutions across the country, when a patient comes in and they get a urine drug screen, even if they're using xylazine, it won't be detected because that particular institution is not testing for xylazine. University of Pennsylvania, we developed a xylazine screen in 2021, I believe, but it is still not included in a routine screen. What that means is that in order to detect xylazine, the provider has to be suspicious that it might be present, and they need to generate an order to specifically look for xylazine. We're in the process of fixing that. Other institutions have either don't have the test or they haven't made it widespread. Xylazine toxicity, of course, one of the other challenges is that when people overdose, xylazine toxicity is not reversed by naloxone. Now, that is only a partial challenge because folks in Kensington, first responders, have learned how to modify their initial response to an overdose in recognition of the fact that many people in the Philadelphia area are overdosing with fentanyl combined with xylazine. And that includes the use of supplemental oxygen. Many first responders actually also have bought and use a pulse oximeter to guide thinking, and basic maneuvers to make sure that the airway is patent. Repeated exposure leads to dependency and withdrawal, which I've also talked about. The withdrawal symptoms are not managed by the drugs that are used for the treatment of opioid use disorder. There's no approved medications for the use for the treatment of xylazine withdrawal, but I'm going to share with you what we know to date with regard to treatment options. And we're just now learning about improved methods of how to take care of these wounds. So, on the inpatient setting, where some of the initial learning was done our first learning was done in the inpatient setting rather than the outpatient setting, is that we recognize that if you don't treat opioid withdrawal and xylazine withdrawal, the patients are going to self-discharge, only to return or not survive their next their progressive health issues. And so individuals have been learning basically on the fly how to care for these individuals. Some of the first tricks that were learned were actually by some of our ICU colleagues who recognize that either by happenstance or because they're deep thinkers, that dexmedetomidine issues actually will treat xylazine withdrawal. And so patients who ended up in the ICU for bacteremia or septicemia or for this aggressive care of these large wounds were placed on dexmedetomidine infusions. And then if the fusions were tapered slowly over 2 to 4 days, the xylazine withdrawal symptoms were treated. On the inpatient setting on the floor, we were slower to the party in that we saw patients who were experiencing terrible withdrawal, and it was assumed that withdrawal was due to high fentanyl tolerance, and patients were rapidly up-titrated with opioids in an attempt to try to treat the withdrawal unsuccessfully. And then over time, it was recognized that xylazine combined with opioids was the issue, and xylazine withdrawal needed to be treated differently than the drug used to treat opioids. So the initial protocols led to dexmedetomidine infusions. They were titrated based on symptom burden up to 0.2 micrograms per kilogram per hour, often up titrating based on the presence of hypertension, and then the higher levels were adjusted when patients developed hypotension, and then the drug was tapered over several days. Some of the key treatment points related to xylazine withdrawal is the following. First of all, one has to recognize that individuals are using both fentanyl and xylazine, and so it should be expected that this withdrawal, if they're users who are injecting drugs in Philadelphia, that it's likely that they're going to experience withdrawal from both drugs simultaneously. The symptoms tend to overlap, but the symptoms attributed to xylazine include anxiety, irritability, restlessness, hypertension, if they're adequately hydrated, tachycardia, and diaphoresis. Diaphoresis occurs more often with xylazine than it does with opioids. And one key issue that I point out that folks in the outpatient setting have pointed out is that many patients who are actively using drugs present or are initially seen by healthcare providers. They're noted to be malnourished and relatively hypovolemic. And so hydrating these individuals is actually quite important. Symptoms generally start 6 to 12 hours after the last use, with opioids, 8 to 24 hours after the last use of xylazine. Symptoms may progress to consistently elevated blood pressure, tachycardia, and tremulousness. ICU admission for the treatment of these symptoms or addressing the symptoms is rarely needed. And a hallmark, of course, of xylazine withdrawal is the presence of symptoms even when aggressive treatment for opioid withdrawal has been completed. Now, what's the first line of treatment for xylazine withdrawal? It's clonidine, 0.1 milligrams every 6 to 8 hours, generally scheduled, not PRN, and titrated to effect, up to a maximum dose of 0.3 milligrams every 8 hours. There's a need to monitor these patients for hypotension and oversedation, particularly when giving the drugs scheduled, and particularly given the risk that the patients are hypovolemic. And that's particularly in patients who have compromised renal function, advanced age, or overall frail. And of course, as I've already mentioned, patients experiencing xylazine withdrawal can be expected to also require treatment for opioid withdrawal. And of course, the other opposite is true, is that if the xylazine withdrawal is effectively treated, the medications for opioid use disorder with methadone and buprenorphine can be effective. The opposite holds true. I've spoken with the medical directors at Jefferson's methadone treatment program, and for a while they were having significant underuse of their beds. And what the director was stating is that patients presenting for intake initially received their medications and then would not return. And their initial thoughts was that this was a fentanyl effect, similar to the initial thinking of patients experiencing withdrawal in the inpatient setting. But as we became more aware of xylazine, what was likely happening is that, yes, methadone may need to be dosed more aggressively in individuals who are using fentanyl compared to those who were using heroin in the old days, but also one needs to use methadone to treat the opioid use disorder and also use clonidine or other medications to treat the xylazine withdrawal. There are additional adjuncts that can be used to treat restlessness or agitation attributed to xylazine withdrawal. Gabapentin or pregabalin can be effective for both withdrawal symptoms and associated with pain. The starting dose of gabapentin is 300 milligrams 3 times a day. Olanzapine can be effective for nausea, vomiting, insomnia, and severe agitation, and some for anxiety. The dose is usually a 5 milligram one-time dose, and then 5 milligrams twice a day PRN. And again, that dose is cut in half for older adults or frail individuals. Hydroxyzine, 50 milligrams Q6 schedule, can also be effective for severe anxiety. Now, as I just mentioned, xylazine can have a significant impact on outcomes associated with treatment for opioid use disorder. Philadelphia methadone treatment programs reported that they were 50 to 75% of their capacity due to inabilities to successfully admit new patients. And we think that issue is probably due to two different issues. One is the federal and state regulations regarding initial dosing is too low in people who are using xylazine. And until recently, they were not concurrently treating xylazine withdrawal for those folks. Lastly, they were also struggling with being able to have a warm handoff from the inpatient admissions to outpatient programs. But there's actually been some significant progress with regard to initiating methadone or buprenorphine for treatment of opioid use disorder and initiating treatment for xylazine withdrawal in the inpatient setting, and then continuing that in the outpatient setting in an effective way. Now, there are challenges, of course, in treating xylazine withdrawal in the outpatient setting. There are certainly few programs that are ready to be able to address xylazine withdrawal in this setting. Most treatment programs don't have the resources, including the finances or access to use clonidine, and most don't know how to properly dose the drug, although that is rapidly changing over the last several months. So what I just wanted to end by briefly talking a little bit about what policy actions have occurred. Again, DEA requested a scheduling review on October 21st. They submitted additional data to the HHS in September 22nd. That review still is ongoing. In November 2022, the FDA issued a warning. In April 23, ONDCP declared Xylazine adulterated, fentanyl adulterated with Xylazine as an emerging threat. And earlier today, ONDCP released a federal action plan with regard to addressing adulterated fentanyl. In the state, several states have issued warnings, as well as several local health agencies, including Philadelphia, have been innovative and proactive in issuing warnings and facilitating discussion on how to treat xylazine-associated injuries. And several states have done scheduling, including New York and Florida, and the governor of Pennsylvania recently initiated a plan to schedule xylazine. So in summary, in the Northeast United States, individuals who are using fentanyl should be expected to also be using xylazine, whether they're aware of it or not. Xylazine withdrawal can be severe and often occurs concurrently with opioid withdrawal. There are treatment options for xylazine withdrawal in the ambulatory setting, or the drugs include scheduled use of clonidine combined with gabapentin, and then PRN, olanzapine, and hydralazine. Xylazine-associated wounds respond well to discontinuation of xylazine, hygiene, and basic wound care. They respond poorly to aggressive surgical treatment, and our surgical colleagues are working hard to learn about how to try to properly treat xylazine-associated wounds. Thank you very much for your help, or for your attention. And if I can figure out how to stop sharing, I will. I may have already blown it, so somebody smarter than me might have to figure that out.
Up next to the red leave button, do you see that?
Oh, there it goes. I found it.
There you go.
Thanks, Lara.
Is it time for questions yet?
Dr. Carter has a question.
Oh, absolutely.
Dr.
Be happy
Ashburn.
to answer.
Actually, I have two questions. They should both be brief. During an earlier slide, you noted that xylazine always takes a ride with something like fentanyl or something else. Its chemical cousins are used in the operating room without needing a ride. Can you tell me what the basic biochemical differences are that make xylazine require a ride when its chemical cousins do not?
I think that's an excellent question. I don't think it's an issue of xylazine requiring the concurrent use of opioids or other drugs. I just think that that is the current state of the illicit drug supply, and that xylazine is combined with other drugs, most often fentanyl. Interestingly enough, and we don't know, of course, what tomorrow will hold, xylazine mixed with fentanyl is seen commonly in the drug supply intended for snorting or for injecting, but has not been seen nearly as widely in the counterfeit pills. As you know, the counterfeit pills that are sold as oxycodone are now essentially fentanyl, and that's why there's been a number of drug overdose deaths with first-time teenage users who think they're buying oxycodone and then use up to 3 milligrams of fentanyl, which is almost always a lethal dose of fentanyl, and die after the first use. But at least the data that I'm aware of, that I've seen that are publicly available, show that those tablets are not contaminated with fentanyl yet. but the drugs used for injection and snorting are.
Thank you. That's wonderful. My second short question. Earlier, you said that Puerto Rico was the host of most of our xylazine, but that's not really being used to flood the Northeast. I am the regional medical director of the Northeast, if that helps you at all.
And the question is, well, let me see. I think I'm going to answer your question. Correct me if I'm not. I think from a historical perspective, it's important to note that illicit use of xylazine that became widespread and was first noted to be a public health issue, where those initial reports came from Puerto Rico. And anecdotally, it's been noted that the progression of xylazine to the Northeast corridor followed the normal immigration patterns from Puerto Rico. However, there's no reason to believe that the illicit use of those drugs is generated by Puerto Rico or Puerto Ricans. And in fact, the death rates are occurring more often in African Americans and white individuals and less in Hispanics. And so I think from a historical perspective, it's interesting to note that Puerto Rico has been struggling with this for a decade before we have, but there's no causation, if you will. And just like folks from California might blame us for the spread of xylazine from east to west of the continental United States. The drug supply seems to be coming from online drug suppliers based often in China, and the drug mixing is actually occurring in the United States and to a lesser degree in Mexico.
Well, that was exactly my question. So thank you so much, my friend. This was an excellent presentation.
My pleasure. Thank you.
Doctor, in your slide showing the increase in use or availability of xylazine, did you also note a significant increase in the availability or use of PCP?
I'm not associated with xylazine.
No, just on the graph. I thought that one of the other medications or drugs that you noted was PCP, because we've seen that at the Philadelphia Department of Prisons, or at least anecdotally, we think there's a lot of PCP being used.
I will tell you that that data came from the Philadelphia Department of Health. Let's take a look here. The PCP numbers have risen historically over time, but the number of deaths associated with in individuals who have PCP is about 10% of the total.
Thank you.
I saw the heroin deaths were noted to drop significantly. Is that because the heroin is mixed with the xylazine? So you use xylazine as the cause to go up?
That's actually likely due to the fact that heroin has effectively been replaced by fentanyl.
Fentanyl, okay. And also, you mentioned that the University of Pennsylvania detected a screen, although it's not routine. Would they be sharing that with other hospitals in the area?
There are other institutions that currently do have xylazine testing, and I mentioned that as an anecdote in that, in my opinion, the easier we make it on healthcare providers to do the right thing, the more likely they are to do the right thing. And I actually think that that making xylazine testing more readily available and easy to access is going to make it easier. And at Penn, we shouldn't require, in my opinion, should not require individuals to ask for xylazine testing, but rather that should be part of the general screen. Now, the next big step, of course, will be urine dip test strips. There are test strips that have been validated for testing drug supply for xylazine, which, again, in my opinion, at least in Philadelphia, have limited value in that almost all of the drug supply for injection is going to test positive for xylazine. It's not going to give you quantitative data on what percent the sample is xylazine versus not xylazine. So its usefulness is going to be limited. There are indeed harm reduction programs that have a limited footprint in Philadelphia that allow or offer testing of samples so the user knows what's in the drug samples and provides some qualitative measure, which might actually be helpful. How widespread that becomes and other regulatory barriers to that in a widespread area is going to be challenging. But I think a urine drug test that provides rapid testing for xylazine is underway. There's one test strip that's under active testing that is an isolated fentanyl xylazine test strip that because there are ED doctors basically say, we'd like to know right now when somebody comes in for an overdose as best we can what the patient is taking. I'm sure in your setting, that would be helpful for you as well.
Yeah, that would be. Thank you.
You're welcome.
How far away from approval is that that development, you know?
I don't, but I will tell you that surprisingly, people can do things quickly when attention and resources are pointing in that direction. And my personal hope is that the action plan that was released today and the increased focus of many organizations on this issue will facilitate that. I am aware of at least 2 different companies that are actively looking for test strips and seeking funding to get test strips. One of them is my own institution. I'm not affiliated with that, but I'm aware that they're doing that.
If you need a test site,
I'll let you know, but I would love for us to get to that area. But the good news is that the regulatory pathway for getting test strips approved is much less challenging than getting a new device or a new drug approved. And so I'm hopeful that we'll see that sooner rather than later.
very good.
Dr. Carter, you have another question?
I do. Of the few places that offer a xylazine test strip, is it a quantitative test or a qualitative test, please?
On the test strips, most test strips are only going to detect, they use RIA technology. They're only going to tell you whether or not it's present or not. It will not tell you. You would need GCMS in humans, usually serum sampling or GCMS testing of urine samples will tell you concentrations. But even that is usually something that usually is a 24-hour turnaround time and clinically is less valuable to the clinician. If we know that xylazine is present, and in theory, I would actually say that if you have somebody who's an IV injection user in Philadelphia, they're using fentanyl. And I would actually argue that probably the best route is to concurrently treat them with clonidine, at least for the first 3 to 5 days to prophylax against withdrawal from xylazine. Now
Okay, thank you.
That's
Yes.
my individual opinion. I actually think that we're still under treating xylazine withdrawal, and I would strongly advocate, at least in my institution, if somebody's an IV drug user, that we try to do that whenever it's medically proper and not contraindicated. But I think that this begs for data to support that, which should be in theory obtained by qualitative and quantitative urine, proper urine drug screens and outcome tracking of patients who receive prophylactic treatment with clonidine on how well they do on withdrawal.
I agree with you. Anything I can do to help, please let me know.
Well, I will tell you that I've had the opportunity to come to the Philadelphia prison system twice now, and I've been very, very impressed with the work, the proactive, innovative, leading edge work you're doing on aggressively trying to treat these individuals who are incarcerated for opioid withdrawal. And I have no doubt that that you're going to take proper messages to try to address xylazine in the individuals who are coming in. And my only hope is that you're aggressive at as best you can at collecting data or at reporting your experience, because I think that there are a lot of places that can learn from what work you're doing, and which would have a significant impact on the whole incarcerated population. You deserve credit and recognition, but also you have something to teach people.
I agree. Thank you.
Well, thank you so much for having me.
Doctor, thank you very much. I think we're going to have more questions for you after we've had a chance to digest this material.
Delighted to help in any way I can. I'm actually to help you in any individual projects you have going forward. I'd be delighted to do that. I think your work you're doing is really important.
Thank you.
So do we have any more questions for Dr. Ashburn while we have him on the stand?
Coming from that group, your group, I'm not sure I like that term.
Well, we appreciate your time and we appreciate your presentation. It was very, very informative.
All right, thank you so much. I appreciate
Yes,
your
sir.
patience and willing to come.
It was
Take care.
great. Thank you.
Thank you. Thank you very
Thank
much.
you, everyone. Thank you, everyone, for
Bye-bye.
attending. I will have this recording for you.
Thank you.